the second presentation by Professor Ashraf Omar, Cairo University. He will speak about non-invasive diagnosis in liver disease.
بسم الله الرحمن الرحيم. كل سنة وحضراتكم طيبين. First, I would like to thank Professor Dr. Amal al-Bishlawi for inviting me to be with you today in your very successful conference. A very important topic now, which is the non-invasive diagnosis of liver disease. By now, you know, after the presentation of the last speakers, Professor Hanal Karasi, the chronic hepatitis C and the natural history of any injurious liver, like viruses or other than viruses, the liver may proceed for chronic hepatitis, cirrhosis, and established liver cancer. For the cirrhosis, actually, fibrosis is the precursor of cirrhosis. Liver fibrosis refers to the accumulation of tough fibrous scar tissue in the liver. When the hepatocytes are injured, the immune system is activated to repair the damage. And here's the pathogenesis of liver fibrosis, the activation of hepatic stellate cells by whatever injurious agent, and this will proceed for the accumulation of fibrous tissue very shortly, and there should be a balance between the activation, deposition of the fibrous tissue and the degradation of the fibrous tissue. When the deposition is higher than degradation, so the fibrosis and cirrhosis will be established. It's very important to estimate the severity of the liver fibrosis. That might help predict liver-related morbidity and mortality, of course. And by now we are thinking about the non-invasive methods, which could be indirect biomarkers or direct biomarkers or imaging modalities. If the non-invasive methods provide a clear-cut assessment of the hepatic fibrosis, then further assessment with liver biopsy might not be needed. However, the liver biopsy still is the gold standard of our evaluation for liver disease. Why we need to assess liver fibrosis? Actually, to determine the prognosis, to identify patients who require antiviral therapy, monitoring disease progression, monitoring patients' response to treatment, and monitor regression after therapy. Here is some of the methods that we can use to assess the severity of fibrosis and cirrhosis, either by direct or indirect biomarkers, in the future proteomics, liver imaging, and of course the gold standard liver biopsy. However, the liver biopsy is invasive, carries the risk of complications, as you know, prone to sampling errors, prone to inter or intra-observer variability, and it is not suitable to be repeated every now and then, and it is still costly. Here are the scoring system, how we can stage the fibrosis. We have 5 scores starting from 0 to 4 by the European Society of Liver Association. We have from the 0 to 4, no fibrosis to severe fibrosis and cirrhosis, and the most applicable kind of scoring is the Metavir scoring, starting from no cirrhosis to portal central septi and established cirrhosis. Here is the Metavir scoring system from 0 to 4, 5 scores from 0 to 4, and one of the benefits of getting a liver sample is to assess the inflammatory scale or the degree of inflammation, which could be from 0 to 3. What about the non-invasive measures, which I think it's important now for all of us because of the liver biopsy and the problems with liver biopsy. Here are the most of the issues that we can use for the evaluation of liver fibrosis and cirrhosis, either by the direct serum markers, which is not commonly used actually, the hydrogenase, laminin, procollagen 1 and procollagen 3 and so on. However, the most applicable, common used sorry. Commonly used methods are the indirect ways of evaluation, as well as imaging by the fibroscan and the RV machine. The ideal biomarker should be liver specific, level not influenced by alteration of the liver renal or reticuloendothelial function, can measure the stage of fibrosis accurately, and should be easy to perform. One of the examples, the APRI, which is very easy, cheap, depends on the AST level over the upper limit of normal of AST over the platelet count by 100. And here is an example of how can we calculate or use it to calculate the liver status. Patients, 61-year-old patients with chronic hep C virus infection, analysis AST is 120, upper normal is 40, and the platelet count is 5,000. So we can easily estimate by this simple equation the level, the level of the fibrosis. 6 means the presence of an advanced fibrosis or cirrhosis. Another method, which is FIB4, based on the age, the AST and the platelet count, forms an index, one of the best for the evaluation of fibrosis. Depends on the platelet count, the gamma GT, the age, and the cholesterol level. And here is our score, the EG score. We nominated as an EG score, which is highly specific, based on the CA19-9, the age of the patient, the microglobulin, bilirubin, platelets, and the albumin. And we have been validated our scoring system versus other methods of evaluation of liver cirrhosis, and we find that it has a very high sensitivity and specificity in different stages of the FIB score as compared to others like APRI, FIB4, and FORNS. We also did compare other, we have also publications comparing the liver biopsy versus the non-invasive technique. And we came to another non-invasive method, which is the imaging. We have different types of imaging technique that we can use to evaluate the liver fibrosis and cirrhosis based on the shear wave. We have the fibroscan, we have the RV machines, both are present in our country, and other which is not available in the country and not commonly used as well. The transient elastography, which means the machine or the fibroscan, we have the shear wave elastography, the RV, the Elasto PQ Philips company, real-time elastography, Hitachi, and so on. Other machines like supersonic machine, virtual TIQ Siemens, and so on. And lastly, the MRE. The most commonly used and has been recently 2 years ago or 3 years ago had the FDA approval is the fibroscan, which is available since years ago in our country, measures the velocity of the low frequency elastic shear wave propagation, and the velocity is directly related to the tissue stiffness, and this stiffness tissue is faster shear waves propagation in the fibrosis areas. The measures performed on the right lobe of the liver, patients lying on his back with the right arm fully abducted. The probe must be kept perpendicular, and we have to have 10 valid measurements. And actually, it measures the liver stiffness in a volume that approximately 1 centimeter wide by 4 long and 24 to 68 millimeter below the skin surface. The results are expressed in a kilopascal, and they range from 2.5 to 75 kilopascal. The normal is 5. Here is a picture of the monitor of the machine. It should be 10 valid measurements with a success rate should be above 60%. And the IQR, which is the interquartile range, reflects the variation among measurements should be less than 30% Otherwise, the measurement will not be valid. Here is the transit elastography, the correlation between the stiffness versus the stage and versus the different types of diseases from hepatitis B, C co-infected with HIV, chronic cholestasis disease, alcohol, NAFLD, and so on. Every kind of disease has its own measurement and its own scale. One of the important scales, which is Castera scale, Castera et al., put his cutoff correlation with the METAVIR fibrosis score, so we can find from F0 to F1 ranges from 2.5 up to 7 kilopascal, F2 from 7 to 9.5, and F3 from 9.5 to 12.5, and F4 above 12.5. A very important issue is we can see that F4 has a very wide range. F4, by the way, is the established, F4 is the only established cirrhosis. So above 12.5, so we can say with comfort that this patient is having an established cirrhosis from 12.5 up to 75. So this is a very important point. And from this figure, we can apply, we can ask for an upper endoscopy to evaluate the patients and to evaluate the portal hypertension if the patient is having esophageal varices, other complications as well. The guidelines for hepatitis C put some correct interpretation with the fibroscan. The values increase after meal, so the patient should perform a fasting for at least 2 hours before. IR2, as I've mentioned, should be less than 30%. Serum amylases, enzymes should be less than 5 high. X probe should be applied when the patient is having BMI above 30 grams per square meter, or if the skin to the capsule distance up more than 25 millimeters. Of course, there should be absence of extrahepatic cholestasis, absence of right heart failure or any kinds of hepatic congestive hepatopathy, absence of ongoing excessive alcohol intake. All these points should interpret with the proper evaluation of liver fibrosis and cirrhosis. What about the benefit of fibroscan? Actually, we can follow up hepatitis C virus after SVR, and early improvement of liver stiffness does not appear to reflect a regression of fibrosis, but rather a decrease in the necroinflammation when we have a patient having a high liver enzymes before treatment. And we got a certain figure by the fibroscan, then we repeat again the test after cure, the significant reduction, first due to the significant reduction of the inflammation, not a real regression of cirrhosis. The real regression of cirrhosis starts 1 to 3 years after follow-up. This is an important point. Cirrhosis, yes, established cirrhosis. Significant portal hypertension, we have some figures, starts from 13 to 34. This coincides with significant portal hypertension. If we have less than 20 kilopascal with a platelet more than 150,000, this can exclude significant varices and no need for endoscopy. So we can rule out endoscopic indication when we have a figure less than 20 kilopascal and the platelet count more than 150,000. We can apply also for follow-up after hepatitis C virus treatment, and we have cumulative incidence of HCC within 3 years was high as 38% among patients with a baseline liver stiffness more than 25 kilopascal. When we have an increasing kilopascal, the probability of having HCC definitely increased. And compared to 0.4% among patients with a value of less than 10 kilopascal. So we can put the fibroscan as one of the best screening method for the probability of evolution of liver cancer. Also, it has been put in the guidelines, as we see, the guidelines for the treatment of hepatitis C. Before treatment, evaluation of the F score by one or more non-invasive fibroscan with other biomarkers to evaluate properly the F score before treatment, and after follow-up after treatment. Also, published data, Egyptian published data with a very good response. 77% of responders after treatment with sofosbuvir-based treatment, and 81% of cirrhotic patients showed improvement in liver stiffness measurements at SVR12. It was 14 versus 11 kilopascal. Also, there was a significant improvement in the FIB4 and APRI score at SVR12. It also now recently in hepatitis B virus treatment guidelines, recently in the last month, it is based, the naive patients based on two things: the fibroscan measurements and the liver enzymes. When we have even a normal liver enzymes, however, the kilopascal is above 9, we have to treat immediately, irrespective to the liver enzymes, irrespective to the DNA level. As you know, in the past, we are evaluating the liver enzymes and the quantitative PCR to go for treatment or not to treat. By now, we are the treatment based on the estimation figure of the fibroscan. If it is above 9, and even with normal AST/ALT, and even without the evaluation of hepatitis B virus DNA, we have to proceed for treatment. Of course, when we have an elevation of liver enzymes, and also we have a high, more than 12 kilopascal, we can proceed immediately for treatment. The point is in the gray zone. Sorry? أيوه. أنا بنتكلم على hepatitis B. كله B. C ده قصة تانية. This is for the hepatitis C, by the way. The point is in the gray zone. The gray zone is when we have an estimate between 6 and 9. At that point, we may think to proceed either to put the patient at follow-up, monitoring and follow-up, or we can proceed for liver biopsy at that time. Also, we have published recently in the last EASL hepatitis C summit the evaluation of liver stiffness as a predictor of liver cancer ablation outcome after percutaneous microwave ablation or transarterial chemoembolization, and you had very good results. There is some disadvantages, which is in the presence of the presence of ascites, morbid obesity, and so on. However, the advantages are really very frequent. Another machine, which is the acoustic radiation force impulse, which is ARFI, which is also present in our country and in our department as well. It is based under ultrasound vision. Select the best area of interest. We apply for an area of interest of the liver, and we can, at that area, measure the shear wave velocity per meter per seconds. The higher the tissue stiffness, the higher the shear wave velocity. And we have, of course, different cutoffs. Another real-time elastography based on a color map. When when we have hard tissue, the areas are colored blue, intermediate tissue areas green, soft tissue are red, and so on. Lastly is the MR elastography. It's actually very expensive because we have to have an MR. It's very costly, time consuming, and it's not still very much applicable. However, it is accurate in the evaluation of liver fibrosis and cirrhosis. In summary, liver biopsy continues to be the gold standard for diagnosis of other causes of liver disease and establishing severity of fibrosis. Radiological imaging using ultrasound transit elastography shows the most promise of non-invasive technique for identifying cirrhosis and stratifying stages of liver fibrosis, and also stratifying, of course, treatment. The best is to use combined imaging and serum markers for more precise fibrosis assessment. Thank you very much.
Thank you, Professor Ashraf Omar.